Thank you very much, and I would like to thank again Professor Duseja and colleagues for the most kind invitation to be with you. Now, PPARs in PBC, why should we think about PPAR targeting drugs in PBC? Now, PPARs, so peroxisome proliferate activators receptors, are nuclear receptors. And when a ligand binds to such a nuclear receptor, you will get downstream changes in expression of genes. For the PPARs, it's mostly transactivation, which has an impact on metabolism, lipid metabolism, cholesterol, also bile acid metabolism, as I will show you, glucose homeostasis and cell differentiation. But by another mechanism of transrepression, there's also an important anti-inflammatory effect. Now, the PPAR field is quite complex, and I will try to guide you through it a little bit. You have three isotypes. You have PPAR alpha, you have PPAR delta, and you have PPAR gamma. And as you can see here, in the liver, you have a differential expression across the different cell types. So in hepatocytes, cholangiocytes, L6, Kupffer cells, hepatic stellate cells, the expression is different, with, for example, in the hepatocytes, predominantly PPAR alpha expression. In the hepatic stellate cells, it's predominantly PPAR gamma. And to make it even a little bit more complicated, as you can see on the bottom here, there's also a zonal gradient in expression of the PPARs and also in the functions, as you know. So in that regard, it's quite complex. What I would like to detail a little bit more, because it's relevant, of course, for the treatment of PBC, is the anti-inflammatory effect. And what you can see here on the cartoon, first of all, PPAR alpha will increase the expression of enzymes that catalyze leukotriene B4, which is an important inflammatory prostaglandin. PPAR alpha will also, via the TNF NF-kappa B pathway, have an anti-inflammatory, so an inhibitory effect, and also TNF NF-kappa B activation via the toll-like receptor and activated protein 1 is inhibited by PPAR alpha. PPAR delta will also have an impact on the NF-kappa beta pathway, mainly related to the production of VCAM1. And PPAR gamma in orange, also via activated protein 1 and NF-kappa B directly, will inhibit the effects of the NF-kappa beta pathway on macrophages and the production of pro-inflammatory cytokines and chemokines. So the three different isotypes have an impact on different mechanisms related to inflammation and globally have an anti-inflammatory effect. What about their impact on bile acid metabolism? It is summarized in this cartoon, but you can see, for example, on bile acid synthesis and also on detoxification. PPAR alpha has an effect. PPAR delta also has an effect on the bile acid synthesis. PPAR alpha has an effect also on the excretion and the MDR3 pump. And what is also shown here is, again, the impact of the different PPARs on the hepatic stellate cells and on the immune cells. So you have an impact on cholesterol and bile acid metabolism, you have an impact on the inflammatory processes, you have an impact on fibrogenesis. So you have an impact on all those key mechanisms in the progression of an autoimmune mediated disease like PBC. This is also nicely, if you want a summary of it, in the EASL CPG that is already from a few years ago, also highlighting even more also the role of PPAR expression in the ileocytes as an additional factor in this complex pathophysiology. But it illustrates that it makes sense to target the different PPAR isotypes in PBC. Now, another important aspect is the interaction between the ligand and later on the drug, and the nuclear receptor. What is important is that those PPAR receptors, they have a ligand binding pocket, LBP, and the position of a ligand or a drug within that pocket will determine what the downstream effects are, both in terms of effects and side effects. For example, here on the bottom, you have the PPAR alpha receptor, and several drugs with some PPAR gamma activity that have a different position. You see the names there, lanifibranor, We will talk about seladelpar is a little bit mainly PPAR delta, but saroglitazar has an important PPAR gamma component, and you see that they position in a different way in that ligand binding pocket, and that will translate in different downstream effects. So every drug needs to be judged on its proper merit, and it might belong to the same category, but that does not necessarily mean that the effects, downstream effects, will be perfectly the same. That is what's called the selective PPAR modulator concept. This brings us to the issue of safety, and I just said that every drug needs to be judged on its proper merits, but there are, of course, some side effects that are more general related to a class effect. For PPAR delta, that has been characterized a little bit less in depth. We mainly know it for PPAR alpha and PPAR gamma. For PPAR gamma, we know that it can create some weight gain. It's subcutaneous adipose tissue mostly that increases because the adipose tissue function is improved. It can also cause some fluid retention, and it can cause congestive heart failure in people mainly that have pre-existing reduced myocardial function. PPAR alpha can have toxicity for the muscle and the kidney, as you know, and can also have more gallbladder problems and gastrointestinal symptoms. And in general, there is also the potential of bone marrow fatty infiltration, anemia, and of course, elevation of liver enzymes. So, as with any drug class, there are some safety issues that we need to survey. Before going to the drugs, a final point, that's how we define treatment response in PBC. There has been a lot of evolution in that over time, but the most recent definitions are based on this observation about response on UDCA, coming from the global PBC study group, that has shown that if you have a decrease below 1.67, the upper limit of normal for alkaline phosphatase, then you have a significantly improved outcome. And that is mainly the basis in most recent PBC trials for patient selection, UDCA non-responders, and for defining the response. But as you can see here, there have been several definitions of response over the years, and that's also important if you want to compare results across trials, that you have a careful look at how in inclusion non-responders were defined and how also the response in the trial is defined, because most of the trials are second-line treatment after UDCA failure. Now coming to the drugs, first approach, single mono PPAR agonism, which is for fibrates, of course, PPAR alpha. Bezafibrate has been tested extensively. The study that I will show you is, of course, the famous study of Christophe Corpechot. Important here is that the definition of inclusion was not based on the response criterion that I just described, it was based on the Paris II criteria. And also the primary outcome was another definition. It was namely complete biochemical response, which means normalization of alkaline phos. So not a decrease below the 1.67 threshold, but normalization of alkaline phosphate. What were the results? And again, this is too quick. As I said, it's a 2-year trial. Also have a look at the numbers, about 50 patients in each arm. After 2 years, 31% of complete responders. After 1 year, that will be a comparison important for later on, it was 23%. What I just want to show with this cartoon is if, again, you look at other definitions of response, you get other response rates. If you, for example, use the Rotterdam criteria or the Toronto criteria, you have almost 90% response. So really looking into how the response is defined is important to have a comparison in terms of the figures. There was some decline in liver stiffness, which is supportive, of course, for efficacy. There was also, in general, a trend for a decrease in pruritus, another important issue, of course, when we want to assess treatment response, and very important for the quality of life of the patients. But this was statistically not significant. But for sure, there was a trend. In terms of side effects, classical side effects of fibrates, with some myalgia, a few cases of increased enzymes, but in general, well tolerated and safe, and nothing new in this population. Some additional data came later on. This is a retrospective analysis looking and comparing patients only treated with UDCA and then patients treated with UDCA and fibrates. But as I said, it's a retrospective analysis. but showing again that the patients that were treated with both drugs had a better prognosis, whatever way you defined it, overall mortality, transplant-free survival, liver-related mortality. Prognosis was better in those that were on fibrates on top of UDCA. And recently at the ILC, there was a presentation about a combination of obeticholic acid combined with bezafibrate, and what you see here is that clearly the combination had the highest efficacy. This was a biochemical remission, but that's the classical definition, as I just explained previously. Very high numbers after only 6 months of treatment, but also in terms of alkaline phosphatase normalization, again, that's more stringent endpoint. You see after 6 months high rates of responders and the highest rate in the combination therapy, so that's something, if confirmed, will probably also have an impact on future treatment. Another PPAR monoagonist is seladelpar, mainly PPAR delta, as I said previously. Here we have data from a phase 3 trial on top of other available evidence, but the phase 3 trial is, I think, the most important. Inclusion criteria was based on the more recent response, as I tried to explain, so the 1.67 threshold, and also the primary endpoint was based on that response. What did we observe? First of all, in terms of biochemical response at 1 year, and again have a look at the number of patients, about 130 in the active treatment arm and 65 in the placebo arm. You see about 62% of biochemical response and 25% of alkaline phos complete normalization in the seladelpar arm. Some effect on pruritus, it depends on how you measure it, but with one of the measures at 6 months there was a significant impact of seladelpar on pruritus, so that's important also. And in terms of side effects, as I said, they are less well documented for PPAR delta, but as you can see here, mainly gastrointestinal side effects and headache, but overall a very acceptable safety profile. Longer treatment, because this was 1 year of treatment, longer treatment can be beneficial, as has been shown now with the ASSURE trial, but it's open label, so I will not discuss the details, but it seems to confirm longer treatment, sustained effect, and sustained safety profile. Then an approach with dual agonists. First of all, elafibranor, which is alpha-delta PPAR agonism combined. Again, now classical definition of UDCA non-responder for inclusion. Classical definition of the primary endpoint with the 1.67 threshold, but also 50% decrease and normal bilirubin. Here are the results in terms of biochemical response at 1 year, 51%, alkaline phos normalization, 15%, some effect on pruritus, you see a clear trend, but this was in this case statistically not significant. And in terms of safety, we have a bunch of safety data, of course, because this drug has also been used in very large MASLD trials, and it's very safe with very little side effects. Longer treatment, we have now data up to 76 weeks of treatment in a placebo-controlled way, so that's why I'm presenting it here. It increases the number of responders, so at 72 weeks or 76 weeks you have more responders with the classical biochemical response, but also in terms of alkaline phos, you are still gaining an additional number of responders if you treat longer, and the safety is still excellent. Another dual PPAR is saroglitazar, alpha-gamma. It's the only one in this series that has clear gamma activity. We don't have phase 3 data yet. We have the phase 2 EPICS trials that have been conducted. Same inclusion, but a shorter treatment duration, 16 weeks, and the primary efficacy endpoint was reduction in alkaline phos. As you can see here, a clear effect of both doses of the drug. Have a look at the numbers, smaller numbers than in the other trials that I've shown you, but this is phase 2, this is not phase 3, and of course the phase 3 trial is awaited for. As you can see on the right bars for those treated with seladelpar, there is also a tendency to less severe pruritus at the end of treatment, so also there there seems to be an effect on pruritus, which is encouraging. And safety is quite okay. As I said, it's a component with the PPAR gamma activity, so there are a few specific side effects you have to look at, like edema and cardiac insufficiency. But so far, also in other trials where seladelpar has been used, and it's also a drug that is tested in MESL-D, we have not seen any important safety signal in that regard. There's another approach. I discussed monoagonist, dual agonist. There's also a triple agonist, lanifibranor, which we have been tested in MESL-D. Phase 2 has been reported. Phase 3 is ongoing. So far, this drug has not been purposed in PBC, but we will see for the future. So in summary, the PPAR isotypes, they play a key role in the different components that are very relevant to the pathophysiology of PBC. We have seen successful data on mono and dual agonists in PBC. Elafibranor has recently also received FDA approval, and seladelpar and elafibranor are also submitted in the EMA, but there's no decision yet there. We need, of course, long-term studies to confirm both efficacy and safety, and hopefully also to see something on clinical endpoints, but that's difficult in this rare disease. And I should probably say, unfortunately, we don't see very strong effects on pruritus and other aspects of quality of life. Some signals, some improvement, but not very strong, so there's still a lot of work to do there. And with this, I will end the talk about PPARs, but I would like to make a little bit of publicity for the SLD summit that we will organize in January in Estoril, where we will also discuss these drugs, but of course not in PBC, but in SLD. Thank you.